Okay. Thank you.
You're now
Okay.
live.
Thank you. A very good morning to each and every one of us. Abigail Marshall Cutting is my name, and I'm the chair for the West Yorkshire Joint Health Overview and Scrutiny Committee, and a Scrutiny Committee chair for health as well in Leeds City Council. I will quickly want to do introduction of all the board members first, and just to say good welcome as well to all our speakers and those joining us this morning. Well, what I would prefer to do is ask members of the board to introduce themselves first, and then when we get to your agenda item for our external speakers, then you can now also introduce yourself. Just to also let you know that this is actually streamed live on the Calderdale website, and for those that would like to join us and are unable to join us in this group will be able to join us online, but obviously will not be able to contribute directly. So I will start introductions with Councillor Smage. And if you introduce yourself and let us know your authority as well, that will be very helpful. Thank you.
Councillor Liz Smage, I'm Chair of Scrutiny in Kirklees.
Thank you. Councillor Jamil.
Good morning, everybody. I'm Councillor Rizwana Jamil, and I'm from Bradford Council, and I chair the Health and Social Care Scrutiny Committee.
Thanks for coming. Councillor Hutchinson.
Colin Hutchinson from Calderdale Council.
Thank you very much. Councillor Ramsey.
Councillor Jackie Ramsey from Kirklees. I'm really sorry I'm on my phone, so I don't think you can see me.
That's okay. Thanks for joining us. Councillor Rhodes.
Hello, good morning. Excuse me, croaking. I've had that flu thing. Betty Rhodes from MDC Scrutiny Chair.
Thank you very much. Any other councillors? Could you kindly put your full names on your screen? So if you rename yourselves, then I know exactly who you are. If I've not called your name, I'm using my attendees list here, but I do know there are certain councillors that are not here. Any other councillors that haven't called your name? Please kindly introduce yourself.
I'm Councillor Andy Soloway from North Yorkshire County Council, soon to be North Yorkshire Council, and I sit on our Scrutiny of Health Committee. I have a particular interest in services because we get a lot of our services on this part of the county from West Yorkshire, so we're keeping a watching brief on things.
Thank you very much. I'll bring in our Scrutiny Advisor in now.
Thank you, Chair. We've had apologies from Councillor Harrington, Councillor Lee, Councillor Glentworth and Councillor Blackborough.
Okay, thank you very much for that. Any other councillor I haven't called who needs to introduce themselves? No? Okay. I believe we've got deputations. Mike, would you like to introduce that, please?
We've just got to do admissions to the public and minutes of the last meeting, Chair. I'm
sorry, I jumped that. Yeah, my sincere apologies. Yeah, please can I refer you to our meeting, our last meeting on the 8th of September, board members? Any matters arising from that? Yes, Councillor Smage.
Thank you. I just wondered if we'd heard about the actions on the community diagnostic centre plans, because they were to let us know certain information, including where the hub and spoke models would be in Wakefield, Kirklees and Calderdale.
Okay, thank you, Councillor Smage. Mike, have we got any feedback from that?
I don't believe we've had an update on that, but Ian may be able to advise us on the current position.
Hi, Mike. I'm Director of Strategy for the ICB. I wasn't aware that we were bringing an update on that today, Mike, but I can pick it up with colleagues if you'd like an update on that.
Oh, sorry, it wasn't an update today. It was an update following the last meeting, but I'll contact you afterwards and arrange for that to be sent through if that's okay.
Yeah.
Okay, thank you. Any supplementary questions, Councillor Smage, from that?
No, it's just if there were actions, if we could have some information from the actions as to what is happening regarding the information, that would be really good. I think it would help us enormously. Thank you.
Thank you, Councillor Smage. Councillor Hutchinson?
Yes, sorry, it was the same issue, that there were 4 sets of information that West Yorkshire Association of Acute Trusts had told us that they would provide to the committee following the last meeting, which they don't appear to have done so. So if we could request that from them so that they can, and if that could then be distributed to the members of the committee for our information, that would be very helpful. Thank you.
Thank you, Councillor Hutchinson. Yeah, we'll do that. You noted that, Mike?
Yes, Chair.
Excellent. Thank you very much. Any other matters arising from members? Okay, I don't see any, and I would now go to the next agenda, which is public deputations. And I believe, Mike, you will be introducing that agenda.
Yes, we only have one request for a public deputation. That's from Holly Lynch, who's joined us, who's the MP for Halifax.
Okay, you're very welcome, Holly, to our meeting, and lovely to have you here, and over to you.
Thank you ever so much, Chair, and thank you, Mike. So ahead of the discussion item on your agenda today around dentistry, I want to speak to the experiences of my constituents here in Halifax who've been contacting me in recent months and beyond that. On the 1st of November, I presented a petition on access to NHS dental care, and that was signed by 549 people who'd signed that online on my website, in addition to a number of hard copies that we're also able to present. And some of those are still coming back to my office as well. The petition follows a speech that I gave in the House of Commons in June of this year, having been contacted by both dentists and patients, really about the appalling state of access to dental care within the NHS. So to set the scene more generally, I've heard from the British Dental Association that there were more than 43 million dental appointments that were lost between April 2020 and April 2022, which includes more than 13 million appointments for children as a consequence of the pandemic. But at a national level, dentistry is now the #1 issue raised with Health Watch. Almost 80% of people who get in contact with Health Watch as an organisation say they find it difficult to access dental care, with the General Dental Council saying that almost a quarter of the population, so at 24%, report having experienced dental pain in the last 12 months. So that's dental pain, a quarter of the population. More locally, last year, Health Watch in Calderdale contacted every dental practice across Calderdale to establish if it was willing to accept new NHS patients, whether it would register a child, and whether it was offering routine appointments. Every dental practice told Health Watch that it did not currently register new NHS patients of any age. And I know that when neighbouring Health Watch in Kirklees did the same, they had the same experience. It's very much the same experience of me and my team in my office if we've been contacted by constituents where we've tried to do that advocacy and secure them dental appointments. We've also been unable to do that and support them. One constituent reported ringing more than 30 dental practices, each of which told them that it was not accepting new NHS patients. The constituent could find no available practices in Halifax, Calder Valley, Huddersfield, or in Bradford. People have been encouraged to look further afield, but those practices are overwhelmed with their local demands, so going further afield does not solve the problem. When we've made representations on behalf of patients in Halifax, we've been advised to search for practices in Leeds, Barnsley and Wakefield. But if you imagine that parents are very strongly encouraged to only book appointments for their children which don't impact on the school day, to be asked to travel sort of 20 miles plus, even if they can secure an appointment, is just not good enough or acceptable when we're talking about young children in particular. I want to share what one local parent told us. She said, I've been making weekly phone calls to all Calderdale dentists in an attempt to, at the very least, get my children into a dentist, as I value oral health greatly. However, I'm yet to be successful in my goal, which is becoming quite time consuming, as I now have a 3-year-old daughter that has never even visited a dentist and 4 other children who've been without a checkup in 5 years. That's half a decade combined with zero dental care. Another constituent got in touch to tell me that since they'd had no luck finding a nearby practice that would take NHS patients, they were forced to make a 5-hour round trip to the Berkshire dentist that they'd been registered with prior to moving to the Calderdale area. Such long waiting periods are also undermining what little dental work people have been able to secure. So another local person had to wait 5 years for braces. When they finally got those braces, the orthodontist informed my constituent, my very young constituent, that they would need 4 teeth taken out. But having tried everywhere to find a dentist, my constituent told me if they don't find one, they won't be able to keep the braces on, which is just sort of absolute madness. So getting to the causes, excuse me, of the problem, I organised a roundtable discussion with local dentists, which was online during the pandemic. They shared with me the perverse ways in which the NHS contracts are broken down into units of dental activity. And it's this UDA system which is just not functioning. Data from the British Dental Association reveals that around 3,000 dentists in England have stopped providing NHS services since the start of the pandemic. And for every dentist leaving the NHS entirely, 10 are reducing their NHS commitment by 25% on average. The BDA survey from May 2022 shows that 75% of dentists plan to reduce the amount of NHS work they do next year, with almost half planning to change career, seek early retirement, or enter fully private practice. Now, the government recently has made some changes to the UDA system, with the first reforms in 16 years, which I know will form part of the committee's discussion later on in this session. However, the cost of living crisis continues to grip families. More and more people will be completely priced out of treatment by inflation and rising bills and living costs, so the inability to access dental care on the NHS will stand to become an even greater problem, particularly for those with children and young families. So I'll continue to challenge government here in Westminster, but thank you to the committee for your time in hearing me raise these concerns with you directly ahead of that discussion that you'll be having later on as part of this meeting. Thank you, Chair.
Thank you very much, Holly, and thank you for coming to address us this morning on an issue that's very, very key to each and every one of us representing our diverse councils today. And I do know you are speaking for so many other MPs as well as constituents around the country, which is one of the reasons why we do have this agenda on, on our schedule for today. So I am really hoping you're staying to the end of it. Is that correct? Would you stay to listen?
Apologies with other commitments. I might not be able to stay for the whole meeting, but I've certainly got an interest, so I'll try my best, Chair.
Okay, Mike, can I ask at this if she's not going to be able to stay, because obviously it's not the agenda that we're going to straight away. Would we want, is it okay for Ian to just give a response before Holly leaves? Will that be all right?
That's fine, Chair, yes.
Yeah, okay. Ian, over to you. I know we were together last week on this same agenda, so I am certain you should be able to give some update to Holly on where we are.
Yeah, thanks, Councillor Marshall-Katung. Yeah, and thanks, Holly, for the deputation. I mean, we absolutely recognise the issues that you're describing. I guess you set out really starkly the impact of the pandemic on dental services, but this is an issue that's been 20 years in the making, and as you say, it's a combination of funding. It's a contract that I think most people would say doesn't work in terms of what we're trying to achieve around inequalities in dental services, and its workforce challenges, which have been around a while, which have been exacerbated by Brexit, and what we've seen in the last couple of years with the pandemic is a sort of a real catalyst of those challenges, which have been there for a while. So we're absolutely cognizant of that. We absolutely understand the issues that have been raised by people across West Yorkshire. We work really closely with Health Watch, and as you've said, the large majority of concerns we get via Health Watch are around dental. We had a really good session, I thought, in Leeds Scrutiny last week, and a lady called Mandy Sharp came along and spoke really eloquently about her absolutely shocking experience firsthand as well. So as ICBs, we take on these functions from April next year. So the services are currently commissioned by NHS England. the ICBs are taking them on from next April. I was going to spend a little bit of time in the session later on talking about the work that we're doing as an ICB in preparation for that. And as an ICB, we're really trying to get into the position of what's the art of the possible here, recognising there's some things that are within the national control, like the contract, which we've got a role around influencing upwards. There's some things that may be in our control around how we really maximise the flexibilities in the contract that exists and how we build a more kind of holistic and integrated way about thinking about dental services and dental care through the partnerships that we're building as an ICB. So really recognise the points that you've raised and really welcome the conversation. If you want to have a conversation offline, Holly, as well, I'm really happy to do that. I'd be interested to understand a little bit more of the what you've picked up from the roundtable conversations you've had. I guess we're kind of, it feels a little bit like we're all in this together. Nobody wants this situation, but there are a series of blocks that mean that the challenges that we've got are there and actually getting worse. And so thinking creatively about the art of the possible, what we can do together and what we can do to influence national government on this, I think would be really helpful. I'll not say anything else there, Councillor Marshall-Catone, because I realise we've got a more detailed conversation later on, but really up for a conversation on this, Holly.
That's correct. Yes. So I've just seen a message asking if we're dealing with it now. No, we're not. We would just wanted Ian to give Holly a brief update on where we are with this agenda item before she leaves, but to say thank you to Holly. Your deputation has been heard and you will receive a response. Obviously, this is recorded as well. So when we get to that item, you could always go back later on to listen to all of our discussions. But definitely an item that's very close to our heart that we need to see that, you know, people are able to access dental care, whoever you are and wherever you are. So we will be in touch. And thank you very much for coming.
Thank you very much, Chair, and thank you, Ian.
Okay, have a lovely day. All right. Next agenda will be on the update from Yorkshire Ambulance Service. Mike, would you want to introduce this first, please? Mike, are you there?
Sorry, Chair, I'm forgetting to switch myself on. We have the Chief Executive of the Yorkshire Ambulance Service with us to introduce the item. Rod Barnes.
Shall I pick up from there?
Thanks for coming.
Thank you, Chair. Okay, I mean, I'll take the report as read, but just to highlight, since we last met, the huge pressures facing the ambulance sector and the urgent emergency care sector generally, and that's a national challenge as well as a regional challenge. I think it's fair to say when I get to meet up with chief executive colleagues across the 10 English ambulance services, you know, we'd all recognise that the pressures that we're facing at the moment are the highest ever levels that we've seen on a sustained basis. Yorkshire Ambulance Service has been at its highest level of escalation, resource and escalation plan level 4 for the vast majority of the last 12 months. And within that, we see particular spikes on specific days that bring about additional escalation measures on day. And as I said before, that's something that's we're seeing across the whole of the country to a varying degree. The causes of those challenges are many and varied. We've seen sharp peaks in demand. Some of that's been related to waves of the pandemic and COVID, but we're seeing a sharp rise in more recently flu cases, but fairly sustained increase in respiratory issues more wider than just the pandemic, and that's increasing demand for our highest acuity of calls, where we're seeing issues around respiratory arrest and other challenges. There are pressures in capacity across urgent and emergency care at the moment that are impacting on not just the number of calls that we're seeing in 999, but also the number of people who are self-presenting at hospital emergency departments, and the challenges that then spill over in terms of acute bed occupancy and challenges around discharge of patients from acute settings are feeding through into increased levels of hospital handover delays. On a regional level as a service, we've seen our highest ever level of hospital handover delays for the last year or so. But within that, West Yorkshire is in a better position than other parts of the region, and in a better position than the vast majority of other parts of the country. We've seen sustained challenges due to staffing issues, a combination of staff absence during peaks of the pandemic, but more substantially just through to fatigue. We're into our third year now of sustained pressure, not just due to the pandemic, but due to winter pressures, and that is taking its toll in terms of underlying levels of absence that we're seeing just through mental well-being and overall fatigue. And we have seen some higher challenges more recently in terms of staff retention, particularly in our contact centres for 111 and for 999, our emergency operations centres, predominantly the centre in Wakefield. These are on National Agenda for Change level 3, Agenda for Change level 3 level staffing. So from that point of view, relatively lowly paid jobs within the NHS. And so I think we've seen a combination of factors, just the overall increase in cost of living combined with that fairly challenging working environment due to the peaks in demand that we're seeing. As a trust, we're taking a number of actions to try and address that, and I'll come around to that a bit later on. In terms of the nature of demand, it is proving fairly complex. We've seen slightly lower levels of demand and lower acuity calls, but a significant increase in higher acuity calls. So the respiratory arrest, cardiac arrest, and other life-threatening conditions. Overall demand for that level of call is about 20% up. And again, that's a picture that's being seen across the country. That does place additional operational pressures just due to the nature of those calls. They require increased assistance from our emergency operations centres, so to have an longer average handling time, and require more resources per incident than a lower acuity call. So that places additional pressures on resources. Within that, there are a number of actions that we're taking in partnership with other care organisations regionally and within West Yorkshire, really focused on making sure that patients are seen and treated in the correct setting of care for their condition. So there's work going on, which I'm sure members of the committee will be aware of, within our emergency control centre, 999 centre, linking in with urgent community response teams, starting on the pilot work that was done in Kirklees and Calderdale, so that we're making sure that conditions like falls are being routed through for emergency community response rather than getting a 999 ambulance response if that's not needed. And similar work being done in terms of frailty services as well, and that which is now being rolled out more widely. Also having direct pathways into same-day emergency care services where those exist within acute settings, which again helps take some of the pressure off hospital emergency departments. And we've also introduced a new mental health specialist response vehicle within all three integrated care systems in Yorkshire, specifically in West Yorkshire. The vehicle's based in Wakefield, but covers the whole of the patch, and that's got specially trained paramedics who've got advanced mental health training, and they're responding to mental health patients in crisis and signposting them into local voluntary services or local crisis services, again, making sure that people aren't being conveyed into hospital emergency departments, because I think we'd all recognise that that's not the right place for the majority of those patients. Amanda Pritchard did a speech to NHS providers a couple of weeks ago and actually highlighted that work as an example of exemplar practice, which was really good to see. We're also working with our acute partners in terms of hospital handover delays. That work on making sure that patients are seen in the right setting is an important element of reducing pressures on emergency departments and improving handover times. But more specifically, we've been doing some quality improvement work with Pinderfields and Dewsbury Hospital to look at patient flow and what we can do in partnership to help reduce handover times in those sites. And that's been really well received and seen a number of improvements. And now we're looking to roll that out across other sites. But our main pressures in terms of hospital handover delays are in South Yorkshire and North and East Yorkshire. So the priority rollout is in those areas. We've recently introduced new system roles to help support that partnership working. So we've got a system partnership director in place now for West Yorkshire, Rachel Gillett, who started in the last day or two, together with a consultant paramedic, Claire Craft. And those roles combined will be helping to advance that work in terms of getting community pathways embedded, alternative pathways embedded, and linking in with primary care networks and other community providers to help get that collaboration rolled out at scale. The autumn statement that was announced last month identified an improvement trajectory for ambulance services, looking to get to a category 2 mean target of 30 minutes. So category 2 patients include things like stroke and other emergency conditions. The national standard the national standard remains at 18 minutes. And prior to the pandemic, I think most services were there or thereabouts in terms of delivery of that standard. At the moment, in Leeds Wakefield, we're about just above 30 minutes, so just above the improvement trajectory that came out in the autumn statement. But in Calderdale, Kirklees, Bradford and Craven, at the moment for November, we're about 40 minutes in terms of delivery of that standard. So some work still to do, but a number of actions are happening to take that forward and get to where we need to be on that. In terms of recruitment and retention, we're really focused on work in our emergency control rooms, so 999 control room and 111 control room, as I mentioned earlier. That's where we're seeing our highest levels of attrition. So we've put in additional welfare support for staff, specialist mental health support for staff working in those areas. We're looking to introduce recruitment and retention payments. We've actually done that in our 111 control room, and we're looking to introduce that into our emergency operations centre and look at other support that can be put into place. And that's in addition to just looking at things like career pathways and the working environment to try and make that as good as it could possibly be. And one of the things that we introduced about a year ago were therapy dogs, which have been used in some commercial contact centres, and also Leeds Teaching have used it in their intensive care environment. So these are just specially trained dogs that come in, and staff have just got an opportunity to take a break and stroke the dog, just play with the dog for a bit. It just takes some of the stress out of, as you can imagine, really tense working environment, an intense working environment for those individuals. Coupled with that, we've introduced an international recruitment pilot in conjunction with NHS England. We've recruited paramedics from Australia and New Zealand. We had a first cohort of over 30 that came into Leeds and Sheffield, and that's been really well received. A number of the individuals that came over weren't getting the training and development opportunities in their own countries, and we've brought them in on a 3-year fixed-term contract to get that development in Yorkshire Ambulance Service, and hopefully a number will choose to stay at the end of that period. But we're looking to roll out a second wave of that international recruitment in 2023, building on the success from year one. Probably just highlight the work that we're doing in and around community engagement, if that's okay. I'm really pleased at the work that we've done in that area at a time of real challenge. So the report outlines some of the work that we're doing in terms of the Restart a Heart campaign that I know has been running since 2014. We trained over 31,000 school pupils this year and did other sessions in conjunction with football and other stadia. And over the course of the just under 10 years that Restart a Heart has been running, we've seen rates of bystander CPR increase from 39% to over 73%, close to 74% in the county. So that's really pleasing to see that, and that directly leads to improved health outcomes. But we've also been looking to work in partnership with our communities in some of the most challenged parts of our communities. So in Bradford, we've been working with the New Directions Drug and Alcohol Treatment Programme and Change, Grow, Live to give training to people who have got issues with alcohol and the homeless community. Done work with the Catch community group in Hare Hills, Leeds, in conjunction with emergency services and the armed forces, looking at alternative career pathways into public services. And that event was launched just over a month or so ago. And we had over 70 young people turn up to that event looking to volunteering opportunities and career opportunities. And from a sort of target audience that we wouldn't normally attract through just posting opportunities on NHS jobs. So that was pleasing to see. I'm sure people are going to have questions. So if that's okay, Chair, I'll leave it there.
Thank you very much, Rod, for that update. And obviously, most importantly, is about telling us what you are all doing in regards to the challenges that you're currently facing. So we appreciate that. And I would now open the floor to members to make comments or questions. Councillor Hutchinson, over to you.
Thank you, Chair. Taking you back to the response and handover times, my understanding is that these are these are of greater concern in the west of England than they are in Yorkshire and Humber, and within Yorkshire and Humber, the problems of delayed handovers are greatest in York and Hull, compared to West Yorkshire. Is that correct?
It is correct. I mean, I would say that, yes, South West is in a particularly challenged position in relation to handover delays. From our perspective, I would say I wouldn't like to just sort of pin down and say Hull and York. Particular challenges in Scarborough, relative to its size, probably proportionately the biggest challenge for Yorkshire Ambulance Services in Scarborough. But we're also seeing significant challenges in areas like Sheffield and Doncaster, but yeah, York and Hull as well.
What impact does that have on moving resources around from different parts of the region that Yaz is responsible for?
It does result in resources moving, Councillor. So at peak times, you can see you can see that virtually the entire ambulance resource for a particular area at a hospital waiting to transfer patients. So in that instance, ambulances will be moved in from corresponding areas where you've got fairly isolated populations like Scarborough and Hull. The implications of that are a lot more significant because ambulances are moving out of area quite a considerable distance to respond to patients. So there have been one or two instances where we've seen ambulances having to be dispatched from West Yorkshire to patients in Scarborough, for example.
Given that we know that there's been a significant increase in the number of Category 1 calls and I think Category 2 as well, has that been reflected in any change in the number of crewed vehicles within West Yorkshire to accommodate that, or have the numbers stayed static? And if so, why would that be?
No, we have increased both the number of paramedics and the number of frontline ambulances. I don't have the figures to hand, but certainly over the course of the last 2 years of the pandemic, there has been a marked increase. Going back probably about 12 months ago, we increased the ambulance fleet by about 20 to 30 on the back of increased demand, and we're continuing to expand this year.
Okay, thank you very much.
Thank you. Okay, Councillor Soloway.
Just a very quick observation and a question, really. How are you working with other emergency services? I mean, a lot of us have rural areas, but North Yorkshire is particularly predominantly rural. We had an incident the other week in Skipton at a remembrance parade, and the first vehicle that turned up was a fire engine rather than an ambulance to give first aid. And know that in North Yorkshire there has been moves towards the fire service equipping their vehicles so they can act as first responders and potentially ambulances. And I wonder if that is sometimes a solution, because very often the fire service might well be nearer, or the police may well be nearer. Just wonder if that's something that the ambulance service is already doing, or whether it's, it's something that you can answer my question anyway.
Certainly, Councillor Soloway. So it's something that we have been proactive in doing in the past, having co-responder schemes with fire services across the county. More recently, there have been some challenges with that, just not from an ambulance perspective, but from a fire perspective. I think I'm probably not in an expert place to comment on this, but the Fire Brigades Union have been less supportive of staff taking on those additional duties. But certainly there are parts of the patch in Humberside, the fire service are providing a response, and we've got good relationships with the other emergency services, both police and fire, and we're continually looking at opportunities of how we can collaborate together to make sure patients get a timely response, and that's part of our plan going into the winter to do that wherever possible.
Okay, thank you.
Thank you. Any supplementary question, Councillor Soloway? You happy? All right, excellent. Councillor Swift.
Yeah, Kevin Swift, Wakefield. Two questions, the first of which is on the handover issue. You mentioned to Mr. Barnes that you had been doing some specific work with the Mid Yorkshire Acute Trust in respect of Pinderfields and Dewsbury hospitals, and then went on to say that the other work of this kind was in other parts of Yorkshire. Did that reflect a situation where the handover issue at the Mid Yorkshire acute hospitals was generally worse than other parts of West Yorkshire?
In terms of, I would say historically, the scale of the challenge that we've had at Pinderfields, Councillor Swift, has been greater than it has some of the other trusts. I would say probably Bradford and Mid Yorks are the areas where we've got the greatest challenges. Part of the drive to do the work there was because both trusts work to a quality improvement methodology and are familiar with a quality improvement methodology. It was chosen as a pilot because both teams would understand, have a common language, and we'd be able to implement change and capture the learning from change more quickly to then roll out to other areas. But within West Yorkshire, I would say yes, Mid Yorks has had a slightly bigger challenge than some other parts of the patch.
Thank you, Mr. Barnes. My second question, you made a comment that in respect to falls and certain other frailty conditions, that the response to 999 was quite commonly dealt with now on the basis of what I think you referred to as a community-based response. Who and what would that be?
So as part of the drive from NHS England in the last couple of months, one of the strategy documents, policy documents, is going further on winter, and that's tasked places and systems with making sure that fall services are in place across their community. It really does vary in terms of what fall services, who's providing fall services. So sometimes it's a dedicated fall service. Sometimes that can be within a urgent community response team. There are areas of the patch where we've got volunteer falls response service in place. So we supplement what's already there. If you look at some parts of the county, so if I go to Humberside, the fire service are involved as part of that falls response. It really does vary by area, but it's Locala, one of the organisations that are involved in that. So community providers as well as social care.
Thank you.
Thank you very much. Councillor Smage.
Thank you. You mentioned something about, now have I got this right, a recovery delivery target of 40 minutes. And I just wondered, you said there was a number of actions that you were going to take forward on that. And I just wondered if it's possible for you to give some more information on those actions, please.
Yes, certainly, Councillor. The improvement trajectory is 30 minutes. So the actions that we're taking in relation to that are quite numerous. Some of it is around the pathways work that I've already described. So that would make sure that we're using 999 ambulances most appropriately and only dispatching 999 ambulances where there isn't a more appropriate response. So that goes back to that link into moving some of the lower acuity patient demand in our what we'd classify as category 3 or category 4 to some of those community responses, and that would free up ambulance time to respond to the higher acuity category 1 and category 2 calls. Some of it is about the additional recruitment of paramedics, both through our own apprenticeship programs and graduate programs and international recruitment. Some of it is about improving the rates of staffing and processes in our emergency operations centre. So there's probably about a minute. If we can make those improvements, we could get about a minute's worth of improved response just by improving call answering processes within our emergency operations centre. So it's multifaceted really, Councillor, but handover delays as a whole, if I take it across the county, we probably lose around 12% of our operational capacity through extended handover delays. So the work that we're doing in partnership with systems and acute hospitals, if we can make reductions in that area, then there's potentially significant additional operational capacity that we can bring back in to respond to calls.
Okay, thanks. Can I just, because you're saying about the community pathways and you mentioned Locala, and that being one of the areas, the pilot areas that you'd mentioned, but you mentioned that 40 minutes for Kirklees, but Locala and the pilot area is in Kirklees. So how are you going to try to improve the times where you've got the 40 minutes now that needs to go to 30 minutes? How have you looked at that pilot to see whether there's any additional things that can help with that area? Thank you.
There are certainly, there's a scalability, yeah, and this is how we as a system think about resourcing into those community response teams. Staffing is a barrier generally across health and care at the moment. One of the things that we're looking to do, one of the things that we're doing more and more is taking the opportunity. There's a good paramedic pipeline at the moment coming out of universities, and we've built on that to look at rotational roles. So at the moment, we've got a number of paramedics who are rotating into primary care to support GPs in terms of home visiting and things like that. And we've had discussions with community providers about whether we can extend that program to cover urgent community response teams as well, to help that multidisciplinary team approach to responding to patients appropriately. Part of that, we've increased and are increasing the number of specialist paramedics with urgent care training that we've got within the service. So I'm not saying it's a quick fix. Those sorts of workforce capacity issues take time, but there's a lot of innovation and collaboration going on between the services to help bridge those gaps.
Okay, thanks. I was interested to hear about the work you had with the therapy dogs and the help that you were giving to your staff, and I just wondered. I realise it's a very difficult time for the ambulance service, so we wouldn't want to do this to take away resource during difficult times. But I wondered if we could possibly arrange a visit to the Wakefield Centre so we could see, and hear how people are coping for ourselves direct, and understand more about the issues that you have. I wondered if that chair would be something that we could look to when it's right for the ambulance service to be able to support that, so we don't take resources away from anywhere that's needed.
Well, Councillor Smythe, I'm sure we could arrange that. Rod, will that be something you would be happy to welcome us?
Certainly, Chair, we'd welcome that.
Excellent. Thank you very much. Councillor Rhodes. Councillor Rhodes, we can't hear you if you're speaking. You're muted, Councillor Rhodes.
Got you. Yeah. Thank you, Abigail. Thank you, Chair. Good morning, Rod. I made some notes as you've gone along. And firstly, I've noted a comment about the mental illness service. And in relation to that, one of your comments in dealing with it was actually to pass on and get involved with a voluntary organisation to save on admissions, were your words. First of all, could you just give us a brief explanation of what the capability, capacity, and indeed in terms of any qualifications that might be needed in that? Because I am aware of the work of the community mental illness teams, etc. That's the first one. My colleagues, Councillor Swift and Councillor Smythe, have mentioned the waiting times for handover. What work is being done with the various trusts in terms of determining criteria for handover? Because we're all very conscious of the shortfall in our social care system as well. So do you work on a priority basis for handover? That's the second one. Community providers being dealt with, so I won't go into that again. I'm very interested to hear about this 3-year fixed term contract for colleagues from Australia and New Zealand. I'm conscious, obviously, that when these come to an end, the intention is, I would say, for a good percentage of these colleagues to return home. And therefore, you have a gap again. As you're going along with this, you did mention recruitment. So can I ask, in terms of yourselves, and indeed now considering that the ICB will be involved in many things. What is your workforce planning at this stage to accommodate if a high percentage of these nationals from New Zealand and Australia decide to go back home after investing, obviously, NHS money in their training programme? I'm always very conscious, having worked in the health service for over 20 years, and this may sound a bit pernicious, but I'm wondering how much is given back into our NHS, having spent money training. And we see this across many of the public sectors, social care, social services. They get the qualifications and they move on. So that's been cynical, but it does happen. I'm sure you do know that, Rod. So those are my questions, Chair. Thank you.
Thank you, Councillor Rhodes. Can I ask the workforce one first, if that's okay? So in relation to that, it's the international recruitment is part of our workforce plan. It's certainly not a sort of quick fix solution. So the paramedics that we're getting over are graduate paramedics. So from that perspective are qualified. I think as probably, I didn't explain it that well, but some of the challenges that they've got is getting the right work experience to complete their registration. So what we're able to do is give them that urgent emergency care experience in an environment that they might not have. That doesn't apply to all of the international recruits, but it certainly applies to a number that I've spoken to. The graduate pipeline coming out nationally for paramedics is very good. I'm probably going back about 5 or 6 years, but the sector did a lot of work with Health Education England, with NHS England, to address gaps in staffing that we had at the time. Now, as people can imagine, looking at 3 or 4 year graduate programs, so things take time to come to fruition. But last year we had a very strong level of graduate qualification of paramedics nationally, and we were able to benefit from that. We've got a number of universities that we link in with across Yorkshire and got good relationships with. Because of a surplus number of paramedics, we're actually able to recruit a number from the Northeast, in addition to those graduating from within universities in Yorkshire. We've done a huge amount of work as a service to put in place apprenticeship programs, and these are focused on people who wouldn't necessarily think about going to university and doing a 3 or 4 year full-time degree. So we're supporting people to come in on ECA grades and other ambulance support worker grades, and we then support them with their qualification through an apprenticeship program. Again, the strong pipeline coming through from that route, and I'm pleased to say that we've been recognised nationally for the work around our apprenticeship program. It's received a lot of recognition and commendations we're really pleased about. So from a newly qualified paramedic perspective, we've got a good pipeline. The work with international recruitment helps bolster that, because I think it gives us capacity to then rotate some of our clinicians out of the service, not just meeting the service needs, but also the needs of the wider care sector, and we can do things like the rotational programs. From a retention point of view, Councillor Rose, I mean, you've raised a really good point. On one of the things that we've done is put a lot more thought into our career profiles, career frameworks within the organisation. We recognise it's a challenging operational environment to work in at the moment. One of the things that we would want to do anyway, but we've advanced in light of that, is to think about, okay, where can people see their careers progressing beyond graduating as a paramedic? So we've introduced a number of specialist paramedic roles, some of which I was describing earlier, advanced paramedic roles that sit above the specialist paramedic roles, and a handful number of consultant paramedic roles, consultant practitioner roles in the organisation. So from that perspective, we're hoping that that really helps with the retention of staff in the organisation, because they can see where their career's heading and how their career is progressing over years to come. So aligning that with some improvements that we're always trying to make in terms of our culture and our working environment. Hopefully those things will all help to improve retention rates in the organisation.
Thank you for that one, Rod. The other one was in terms of the handover, how are they prioritised between your good self and the trust in order to free up the beds that are needed to get the patients into the hospital? You have a priority list. How do you work to it?
I mean, I wouldn't quite word it as a priority list. I mean, there's a clinical triage, an assessment that's done by paramedics on frontline duties. So they will go through a triage process to assess where the right place for that patient is. Our frontline paramedics who use laptops and electronic patient record, which has got access to summary care records. So they're better informed than they ever have been in terms of that decision making. It's always a risk-based assessment in terms of not just the condition, but the home environment or the environment that patient's in. And we convey about just over 50% of the patients that come through the 999 system would end up being conveyed to a hospital emergency department. There is always learning in relation to that. So I was describing the handover work that we're doing with Mid Yorks at the moment. Aligned to that, there's some other work going on, which is just looking at patient information across the ambulance service, across the hospital, and across the local community to think, okay, well, looking at particular patient groups, if Mid Yorks has a view to that these are patients that aren't necessarily best seen within an emergency department acute setting. There are things that we can learn from sharing that information across providers to look at the human factors related to that. So what's influencing the patient's decision, whether that's phoning 999 or self-presenting at ED, what's influencing the clinician's decision in terms of where to convey. So really, from that perspective, we use that as an opportunity to sort of audit what we're doing and think about the decisions that are happening and are patients going to the places where they need to go to.
Rod, I'm particularly interested in the vision that's up and down the country and the perception of the public out there in terms of the service. Not necessarily associated with West Yorkshire, but I'm sure it has at times, of ambulance being stood outside 8, 9 and 10 deep with patients in that ambulance waiting to be admitted to hospital through the handover procedure. One has a picture of somebody being the last ambulance with somebody more serious in terms of medical need. And I'm trying to get the picture in my mind of how we don't want ambulances doing a series of movements up and down when you have a queue, because you don't naturally have the space. But I'm sure the public out there listening today will have seen these kind of pictures up and down the country. And my question was, how are those clinically prioritized when you have ambulances in a queue waiting? Okay. A difficult one, but I'm assuming that internal system of doing it.
There are councils. So there are a number of decision points that we would go through, and we've developed in partnership with local hospitals and local system partners. I mean, one of the things that we've introduced in the last few months is cohorting, patient cohorting. So in this instance, where we are seeing extended delays at a particular hospital site, historically, an ambulance crew would have taken a patient into an emergency department and waited with that patient until they were handed over to staff within the emergency department. Within cohorting, where we have lower risk patients, lower acuity patients waiting in a queue, crews would work together. So a crew might take responsibility for more than one patient to free up another crew to respond to patients in the community. So at times of escalation, we have that cohorting process in place across Yorkshire.
Okay, thank you for that, Rod. And lastly, briefly, because I see there are two others indicating mental illness, that you would actually incorporate using the voluntary organisations to save on admissions. To know more about that in terms of the professionalism or the capacity of voluntary organisations who used to be the icing on the cake and are now part of a big cake. What qualities of care would said person have? How are they managed in the first place? In the difference between a medical need and a mental illness need? And I think that's a big area of concern. So briefly, Rod, I know there's other people waiting.
Certainly, Councillor, and I'm talking outside my area of expertise, but I'll tell you what I know.
Okay.
So the specially trained paramedics that we've got working on this service have had additional mental health training. We've also got specialist mental health.
I'm sorry, Rod, let me interject. It's the voluntary organisations delivering to those that I am very concerned about. I know about paramedics, I know about the community mental illness teams. It's the people you're handing them over to, I think, is the important issue.
Yeah, I'll pick up on that. So very, very briefly. So we've also got specialist mental health nurses in our control room, and they've worked with the system partners within each patch to identify crisis pathways. So it isn't necessarily every voluntary service that's on that pathway. It will be the recognised services, whether that's a mental health crisis cafe, as well as the NHS mental health providers. There'll be a number of different pathways that are recognised within a particular community. And we will refer into those where they're recognised by places as the right pathway for those patients.
Okay, thank you, Rod. But Chair, can I just ask, I know time is of the essence and we have a big agenda item next. Could I just ask Rod, if you would please send through to your staff there, and I'm not talking about paid staff, voluntary is not paid staff, you mentioned voluntary. Could you please just send into the Scrutiny office in Leeds what voluntary organisations are involved in having a pathway to patients coming out, so we know their capacity and indeed their qualifications to accept them, Rod. That would be very helpful.
Certainly, Councillor.
Thank you, Rod.
Thank you, Councillor Rhodes. So Councillor Hutchinson and then straight after Councillor Smythe before we get back to Rod, so that we can conclude on this item agenda, please.
Thank you. I'll try and be brief. We know that the UK has got a very low number of hospital beds compared to the rest of Europe. So how we use those is really important. The patient transport system is vital to the functioning of the system as a whole in terms of getting patients to hospital on time for operations and other diagnostic care, and returning patients to their place of ongoing care once the hospital has done its business. Is this importance reflected in the commissioning of the patient transport service?
Okay, so before you come back, Rob, Councillor Smythe can come in now and ask a question as well, and then Councillor Ramsey, and then you can respond to all of them, Rod, if that's okay.
Certainly.
Okay, mine's just a quick question. You mentioned about acute needs and primary care challenges, and I'm wondering what work is being undertaken in relation to earlier help benefits in order to ease the pressures in the future. That might not be for yourself, Rod, it might be for the ICB as well. It might be both. Thank you.
Thank you, Councillor Smage. Councillor Ramsey.
Oh, thank you very much. Thank you very much. I've enjoyed the discussion and the debate, and you've given some great examples of partnership working and such. If you were able to fix the system, because at the moment it feels as though things are hugely challenging, where exactly would you start? I'm not talking about particularly your services, I'm talking about generally the whole system.
Yeah, I mean, I think we'd all recognise that pressures in social care are having an impact on health, and you know, probably misquoting Ian's comment from earlier, you know, the challenges in social care have been well known and there for a number of years. Things like Brexit and the current cost of living crisis haven't helped, but there are definite challenges on acute sector beds at the moment through patients who are awaiting assessment to go into a community setting, and we see that, you know, pressures on the back door impacting on the front door.
Okay, do you want to come back on Councillor Hutchinson's point?
No.
In relation to the commissioning of
patient transport services.
Patient transport services. Yeah, I think it's an area that is improving. It has been the poor relation for a period of time. I think it's getting increased focus. There's been an NHS England programme of work running for the last sort of 18 months or so, involving a number of patient groups, looking with providers like ourselves and with commissioners around what can be done to improve. Within West Yorkshire, we were actually part of that work. We've got a Pathfinder programme running at the moment, looking at eligibility criteria. So there is an greater increased focus. I still think there's a bit of work to do, but it does, as you say, play an important role in terms of flow between facilities and making sure that patients get to where they need to be.
Okay, thank you. And Councillor Smage.
Yeah, I was asking about the benefits of earlier help and how the acute needs and the primary care challenges are being discussed, and whether that is some work that is ongoing to try and ease the pressures into the future, I think was my question.
Well, Councillor, certainly it's front and centre, the conversations that are going on within the West Yorkshire system, and the focus is very much on inequalities and looking 5, 10, 20 years ahead. We're involved in a number of programmes looking at inequalities, so you know, it's part of our agenda in a way that it never has been before, but we're probably not best qualified. I know Ian's got his hand up and would be far better to articulate the work that's going on across the system.
Okay, Councillor Rhodes, is that a legacy hand or it's a new? Councillor Rhodes?
I'm sorry. Do forgive me. Do forgive me. I'm
forgiven. That's all right.
Thank you, Abigail.
All right, Ian, did you want to come in here?
Yeah, I mean, just briefly on Councillor Smage's question, you know, we are in a position where demand for services is rising faster than the availability of services due to an aging population, multi-morbidities, etc. And that is creating pressure on services. A big part of our strategy and a big part of the 5 strategies for the places in West Yorkshire, and I think Esther might have touched on some of this in the previous session, is around how we support the development of multidisciplinary teams in communities to work with communities and provide more proactive upstream care for those communities to avoid the situation where there are urgent sort of demands on urgent emergency care services. And that's a big part of our strategy, and that's a big part of the work that's been led in the 5 places, as Rod describes. we are in a position where there is a mismatch between the demand for services and the available resources, and that's been the position for some time, and that will continue, which is why these integrated ways of working are really important, and we see them as part of the solution.
Okay, thank you very much, Ian, and a huge thank you to Rod. I know we have put you on a lot of pressure this morning with lots of questions, but you have done really, really well in responding to them. We will continue to keep a watching brief. We've got a meeting in February, so even if we do not have you on the agenda, A4 update will be very helpful. Councillor Smage has also asked if we could visit, and Mike has kindly put down in the chat group that he will arrange with Helen, and I'm looking at sometime in the new year before our February meeting, so that at least we can give some feedback from what we have discussed today. So on behalf of the board, we want to say a very huge thank you. Members, just give him a smile because we can't see him, just to say thank you and a wave. Truly appreciate it. You're happy to stay if you want to listen to the dentistry item, but if you'd rather do something else, by all means, feel free to leave the meeting. But thank you very much for coming. Right, so we're going straight into agenda item number 7, and that's Yorkshire and the Humber dentistry. And that's, we've got Ian here who will go through that for ourselves. And it's all about discussion about access to our NHS dentistry, not just in one area, but just more specific to West Yorkshire, and of course, the wider oral issues that we currently are all facing. So before I call Ian, Mike, would you like to say something?
Just to say that Emma Wilson's here as well from NHS.
She's here. Oh, fantastic. Okay, can we ask all the people from the dentistry speaking on this agenda to kindly introduce themselves so that we know who you are? Good to see you again, Emma, after a week. So
good morning. Good morning.
Dentistry keeps bringing us together, so that's great. Okay, Ian, if you want to introduce yourself and your team, then that would be very helpful.
Yeah, hi everyone. Ian Holmes, Director of Strategy for the ICB. Doing a double act with Emma this morning. I think Emma's going to talk about the current situation and current work happening, and I'm going to talk about the preparation work that the ICB is taking forward to take on the delegation of these services from April. So maybe Emma can speak first about her parts of the paper, and then I'll speak second, if that's okay.
Thank you. Over to you, Emma.
Good morning. My name's Emma Wilson. I'm Head of Co-Commissioning for Yorkshire and the Humber, NHS England, and one of my programmes is the commissioning of dental services. I will make the assumption, and I hope that's fair, that everyone has seen and read the paper, which does articulate the current situation with regards to dental services, and that for us means the full pathway. That means primary care, high street dentists, community services, and our secondary care arrangements. I think it's fair to say we continue to experience a number of challenges, as we've alluded to. Some of them are compounded by the pandemic, but we're certainly, I've certainly been asked to talk to you previously, so we know that some of those challenges have been there for some time. But I feel that we're now in a position where we are able to recognise and approach improvements in terms of the dental agenda. I think key things I just wanted to take from this and just to highlight for colleagues was the development of the oral health needs assessment, which was something that we had been asked about in all of our previous discussions. And we've now completed the needs oral health. It's a rapid oral health needs assessment for West Yorkshire. And we also have a place-based profile. So for each of your localities, at Wakefield, Bradford, we have a profile. And there's literally a meeting going on as we speak that I've just left chairing, where we are looking at how we can use that information to commission services in the future. The other thing that I wanted to just raise as well was funding that we are putting into our dental practices over the next 4 months to help them with their backlogs. So we have a situation at the moment where it's incredibly difficult for members of the public to access dentists for regular care. And we recognise that it's a number of different issues, not only the pandemic, but also the challenges of the workforce, etc. And many of our practices have indicated that if we could give them some additional funding, then they could secure a workforce to ensure that they could clear some of their waiting lists. The third point is just to reiterate that for many practices, they're unaware of their waiting lists. They will offer patients the opportunity to sit on a waiting list, but have no way of knowing how well validated that is or how urgent people's needs are. So we have also offered them some financial support to make sure that they can validate those lists and communicate with patients more appropriately so that they're clear about timescales and how they would best access those services. So I just wanted to flag those three things, which are improvements, I hope, that we'll start to see a better improved access to dental services over the next 4 to 6 months. Thank you.
Thank you very much, Emma. Okay, Ian, over to you, and then we'll come to the board for comments and questions.
Yeah, thanks, Emma, and thanks, Councillor Marshall-Catung. So, as you're aware, and as I mentioned earlier, there's an expectation that integrated care boards, so the organisations that were established last July, will take on the commissioning of 3 sets of functions from next April. So community pharmacy, community optometry and dental services. And this is consistent with the direction of travel of the Health and Social Care Act, where the idea is you give ICBs, organisations working in places, full budgets for their population, which gives them the best possible chance of joining up care and joining up services around people's needs. We actually had a conversation in the board of the ICB, I think it was 2 weeks ago today, talking about readiness to take on these functions. So there's a paper and a live stream of that conversation, so you can see the way the board approached it. And I think there's 2 aspects to the work really that we're looking at over the next 5 or 6 months in readiness for this. The first is, have we done the necessary due diligence work, if you like? So have we done the necessary work to understand how the service works, how contracting works? Are we clear on the money coming across? Are we clear on the team from NHS England coming across to do the work with us? And are we clear in terms of the future governance and decision-making arrangements? So that's the first aspect of the work. And in terms of the second aspect of the work, it's kind of what we touched on earlier. So have we got a good understanding of the service challenges, the issues that people across West Yorkshire face, and have we got a plan in place to try and address those, recognising, as we've said throughout, that some of those are long-standing and quite wicked issues, really. And in terms of the first kind of set of issues around the due diligence, there's 3 sort of top-level risks that we've identified, really. One is around the transfer of the staff to do the work from NHS England. And this is in the context of a change programme in NHS England, where they've announced up to 40% reductions in capacity in NHS England. So a conversation around that. And that includes things like capacity around sort of complaints, which is the second issue. So really understanding some of the specific aspects of how things are going to work, including complaints. And then the third sort of point is, are we confident that we've got the funding from NHS England in order to be able to commission a service to a standard that we'd like to commission? So those are the kind of key risks identified, and work is progressing with NHS England on those things. And the second part of it, and I guess the part of it that we'd like to get into the conversation with you this morning is, do we understand and are we able to respond to the service and access and inequalities challenges that we face in West Yorkshire? And as we've said, these are challenges that existed long before the pandemic. These are challenges driven by historic funding, a contract which is not that flexible and doesn't really incentivise the right activities, and workforce pressures, where we've got high levels of attrition in dental workforce, which has been exacerbated by the impact of Brexit. So it's a fairly difficult set of conditions that we are taking on from next April. But our focus is, what can we do? What's the art of the possible? What can we do to improve things? And there's probably 4 or 5 things that we're focusing on as part of that. So the first one alludes to what Emma said, is do we understand, where the pressure points are and where the needs are and where the challenges are across West Yorkshire as a whole and within the places that make up West Yorkshire. The second one is what's the art of the possible with the contract that we've got, which we recognise isn't really fit for purpose. So Emma's described in the paper some of the things that we're doing across Yorkshire and Humber around additional capacity. I think she also describes the changes that have been brought in the summer around the contract, which will help, but which isn't a silver bullet, unfortunately, in terms of the contract. So what can we really sort of squeeze out of the existing contract to try and improve things? The third thing, and I think this is where the ICB potentially has a bit of an opportunity, is what's the sort of the more kind of joined up approach to dental health that focuses on prevention, that recognises the role of GPs working in communities with other partners around, the messaging around dental health. What's the role of working with local authorities and children's teams? What's the opportunity to work more closely with schools around the prevention agenda for dental health? So how do we sort of, almost kind of apply the dental, the challenges we've got in dental to sort of the model of integration that we're trying to build across the ICB? The fourth one I'd say is what's our role collectively as integrated care boards in influencing the sort of the national government and NHS England around this. I think it's quite an interesting time that we're in, where 42 ICBs are taking on these services. All ICBs are acutely aware of the pressures and challenges around these services, which is a national issue. And so what's our collective voice in saying, well, actually, in order to get this right, here's the things that we need to look at. And that might be the contract. That might be things like exemptions for Eastern European dentists to be able to work in the NHS, because we know that was a big issue coming out of Brexit. And what's our role in influencing upwards? So we're working on a sort of a plan around that with Emma and the NHS England team to really sort of squeeze out the opportunities that we can with a difficult set of situations that we inherit, and that's the sort of the focus of the next 6 months. None of those things are a silver bullet. I think it's really important to say that from the 1st of April. We will not miraculously see significant improvements in access to dental, but what I will say is that the board of the ICB, our wider leadership, are absolutely aware of the issues, really keen to address the issues and do what we can on this agenda. The board, to conclude, when we had the conversation in the board 2 weeks ago, they sort of set up sort of 3 tests for us, really, in terms of taking on this service. The first one was, are we confident around the money? Are we confident that the funding coming from NHS England for these services are sufficient to deliver the service, and there won't be money clawed back into NHS England given the wider financial pressures? The second one, do we get the full transfer of the team from NHS England who've got the capacity and the expertise to be able to help us with the commissioning of the service? And the third one is, are we confident that we've got the sort of the flexibilities in the contract and the availability to do things differently, which will hopefully start to improve things. So those are the kind of the tests that the board agreed. And as I say, we'll be working with Emma and the team over the next 4 or 5 months in readiness to take on these services. Thanks, Councillor Marshall-Khatun.
Thank you very much, Ian. As you can see, we had lots of hands up even before both of you finished your presentations. So yeah, it's a full one for us today. So I will start with Councillor Rhodes. Please, can we try and keep it as brief as possible so that everyone can ask all their questions? Thank you.
We will, Chair, but unfortunately, this is one of the major issues across all the patches today. And it does deserve time, and it may be that after today, it may have to come back on an agenda, even through a special meeting if necessary, because our constituents or anybody out there waiting would not expect us today to be brief.
So when I say brief, I'm sure when I say brief, you know what I mean. Totally understand. Yeah.
I do know what I mean. And I'm, as chair of my scrutiny committee in Wakefield, we have, as Emma knows, we've had this on our agenda 2 weeks ago. And I've just listened very carefully to Ian, and I'm sorry to say this, Ian. You spoke about the challenges of taking it over. Those challenges are not going to go away. And at the moment, what people out there want to know is, how do they get dentistry provision for them and their families. When people have no choice and they're expected to go private at costs of money that are exorbitant, at a cost crisis across the country, that is not an answer. And people have messed around too much with this, and I do not see how the presumption that was called a golden handshake and is actually in the minutes as, and I quote, high-performing dentist practices will have the opportunity to increase their activity by a further 10% as many patients as possible. Question 1, if they can't see them now through capacity after COVID, how are they going to see them through a golden handshake? Because the capacity issue of dentists available is the issue. Secondly, it's not been mentioned, but a lot of the practices out there, and people listening, and I hope will take note, that the dentists in the practices are themselves partly to blame because they've decided to go private. So that puts an increased number on the NHS patients that are available. In fact, I do know of one practice already across my patch in Wakefield, where they've decided they're only going to see NHS patients 2 days a week and the rest of the time has gone private. And the blame on this all the time is the contract that was brought up in 2006, I believe, that has never really been sorted out. Now, the patient is the sufferer of the contract at the moment. There's been a big debate, and I'm sure somebody in Ian's team or through the offices out there, it was actually on Good Morning Britain. And people, I hope, linking into this today, will have seen that debate, because it was put to the task of actually getting the head of a dental services to come to the studio to actually answer concerns that were raised about the dental provision all over the country. And what really worried me, and I don't know if anybody else saw it, but please, I did, and I took note of it. The representative from the dental organisation who, from the previous morning, felt aggrieved at comments that had been made, decided, bless him, to come and answer. This is what the public are seeing. We're not seeing workforce plans. We're not seeing golden handshakes. What we're seeing is a public out there who are bereft through pain. They're going to work through pain. And I'm sure our NHS representative here today will remember this. One thing that really worried me was two things in terms of what's happening at the moment. We've people in critical pain because they can't get a dental appointment. And they're in critical pain because they can't afford to go private. We have people as well, and the numbers, it's not been mentioned here, of extractions that are taking place within the mid-Yorkshire are anything up to 100 a week on children. What became blatantly obvious through the national information and sharing on the TV was that, and I quote, the head of the dental services was asked a question about extractions, and it was qualified by comments from the public, and he answered them saying that extractions were mainly being carried out now after, quote, people have been given antibiotics to see if it take away the infection. If that didn't happen, they'd get more infection, they'd get more antibiotics. And he actually said that the problem is with newly trained dentists, what they have is a defense dentistry. And he was asked to explain that. And the defense dentistry meant that some of the newly qualified dentists are very reluctant to pull teeth. So in fact, what's happening is that the antibiotics are being given and given and given until they become an emergency. And that said patient or patients have to go through the dentistry provision through A&E within the trusts. Now, there's something radically wrong. And I feel very strong about this. And it's no use us listening here today, Chair, and thank you, Ian, for coming. What's going to happen in April will happen in April. But I'm afraid the now is now. Holly and everybody else across the country and our MPs and our councillors, no matter where you are, we are dealing with this situation. And I'm afraid visions and plans are part of an issue but what is going to actually happen now? And I'm very, very disappointed, Ian. And you know me a long time, and I'm very, very disappointed. We've just heard from Ian that apparently there's some report that's been looked at in readiness for the ICB board to take on this provision in April. Could I please ask Chair for Ian to answer? Is that report now ready for the Scrutiny Committee to see and comment on? If it is, why haven't we had it before this meeting today, where we would have had a chance to see what the issues are that the report is about? Because believe me, Chair, you know from your experience as well, it's not reports out there that people want to know about. We want to know what the content is so we can scrutinise it. And I'm sorry, I feel very passionate about what's happening. And if today's timing isn't enough, then I think we ought to bring in another meeting early in the new year to bring back people that can actually answer to what's happening and not just concentrate on the future. It's the now we want to look at. And I'm very passionate about the Chair, do forgive me. And I will have to be leaving the meeting at 11:45. And I know there's several other hands, but thank you for the time you've given me on that, Chair.
Thank you, Councillor Rhodes, and totally 100% on every single word line that you have mentioned today. Before I bring in Ian, we've got Ben from Public Health England. I would like you to come in, Ben, because I know you need to leave at 12:30, and it's half 11, and it's already 11:30, but we would give you the time to speak before we listen to board members again, please.
Thank you. I'm actually from Calderdale Council Public Health, not Public Health. And I was asked to just give a bit of a public health perspective on the oral health side of things. Now, I think I've got a lot of sympathy for what Councillor Rose has just said, actually, and I think it's really important that I suppose we focus on what we're trying to achieve for the outcomes for people who live in our areas at the moment. And I think it's quite clear that the number one priority is around equitable access to primary dental services over and above anything else. And I think it's quite easy for someone like me to sit here and say, well, it's all rubbish, but actually I know how much work goes on in the background to try and deal with that. I think there's a real opportunity as we run up to April to have a broad consensus on how we're going to achieve that. I think Councillor Rhodes is right. What we're going to do now, what does April mean? And I think Ian has kind of got that dual challenge of these being told about the commissioning function you have to take on, but also having that oversight of wanting the best health and well-being for the residents. And I think it's important that we almost separate out the two things. So there's what's the function that you've got to do as an ICB, and then what, as a group of partners, do we wish to see for the people who live in our places. I think there's something really important for me about the role of local authority in some of this. So Ian talked about the prevention agenda. I think that's really crucial. And I think we have a role as public health teams on the public oral health agenda. And I think it's not consistent across the patch. And I think that's something we need to think about in terms of West Yorkshire, about how we can be better at that. I think the other big thing for me is around water fluoridation and the opportunities that we've got within changes to legislation to actually have a proper discussion around whether water fluoridation is a thing that we would wish to do in West Yorkshire. It's very difficult to do that at place level because of boundaries, and it is a political issue, I know, but it's the number one thing that we could do that would prevent that rapid deterioration in children's oral health that we're seeing in all of our places, which is leading to some of the things that Councillor Rhodes talked about in terms of children missing school because they're having their teeth extracted, and a whole range of other things associated with that too. I think the other really important thing actually is around not just accessible access and equitable access, but when you do get that access, getting the things you're entitled to. So particularly for children, there's a whole programme of fluoridation that actually is part of the core offer, and it's important that we ensure that our children have access to that primary care in terms of dental care and receive the things that they're entitled to when they do it. The contract doesn't help with some of that, but I think it's really important in terms of us being able to really do some of the things, as Councillor Rose says, what can we do now? Well, that's one of the things we could be doing now, I think. So I'm going to pause there. I think I suppose the one thing I would say is I think it's really important that we focus on what the ICB can do at scale that we can't do at place, and empower the places to be able to do the things that we're best placed to do. And some of those relationships with education, for example, we're very well placed to do that. But I do think it would be helpful to have that as a bit of a West Yorkshire approach rather than the place-based approach at the same time.
Excellent. Thank you very much for Ben for that. That's very helpful. So I will come back to you, Ian.
Yeah,
you
thanks.
had a specific question to answer, so that's why I'm coming back to you.
Yeah, and I also agree with completely the sentiments that the Councillor Rhodes expressed there. I mean, genuinely, the quality of the service, the access to service is not what anybody wants, and it's absolutely not what anybody who's working in the ICB wants. So I absolutely understand that and recognise that. And I think the first question was around how are we generating this extra capacity when there's no capacity in the system, Councillor Rhodes. And I think. And Emma might want to come in on this one. I think essentially there are some practices that are delivering their full quota of dental capacity as measured in the things called UDAs, units of dental activity. The offer is that the practices that are delivering absolutely up to the max, if they believe they can deliver further capacity for a fixed time period, up to 10%, we will give them extra money of underspends from the contract to deliver that extra capacity. So what we're doing is we're rewarding and working with the practices that are delivering up to their limit by offering them more money for more activity. And so that's the idea there. What you're probably doing is you're getting practices to sweat even harder for a period of time, but it's a way of delivering extra capacity in the short term with the fixed capacity that you've got. I think the other thing it's worth mentioning within that is that partly because of the incentives in the contract, you've got dentists kind of treating the wrong people. So someone like me getting a 6 months recall to have a scale and polish isn't a priority, but it's quite financially lucrative for dentists to do that compared with seeing someone who hasn't seen a dentist for 5 years who needs a lot of work done. The extra work to get that person up to a standard is not as financially viable as it is to maintain the teeth of someone who's got pretty good teeth. Again, that's a kind of an issue of the contract, but that's something that we'd want to look at if we're serious about inequalities. On the points around workforce, I think you're absolutely right. I think there is quite high levels of attrition, and I think there are also a high number of dentists who are doing less hours so they can do other work. I think your point around the balance between NHS work and private work is well made, and for me that's a kind of a feature of the contract and terms and conditions. If people can earn more money doing different things, be it private dental work, be it Botox, be it whatever else it might be, then that's a choice that the people are making, unfortunately, and that's losing dental capacity. In terms of the report that went to the board 2 weeks ago, yeah, I mean that's in the public domain. Apologies, I'll share that with Mike, and Mike can share that with you as a group. Really, that was a report that we took to the board saying, look, this delegation is coming. You need to be aware of it. This is the work that we're doing to ensure that we're prepared for it. And that was a conversation that we had in the board. We'll be having a further, more detailed conversation in the board in March as we get closer to the point where those services will be transferred over. But I'll make sure that those papers are online, but I'll make sure that Mike's got them so that you can share them with the group. Emma, I don't know if there's anything that you want to come in on around that.
Yeah, I would support what you just said, Ian. I think the other thing is that fortunately or unfortunately, practices can have private services, and all we can worry about is those NHS services that we commission and contract. So where we are aware where providers or practices are not delivering the services that we would work with them. So in the example that Councillor Rhodes gave, it may well be that actually they're only commissioned to deliver a very, very low number of UDAs. What we're doing, as Ian's just said, is where we have funds is asking them if they could do some more, if they could do more than they have. And we've got some that are struggling to deliver, but we have got quite a few practices who are saying to us, if we can have some longer term funding, more than just a couple of weeks at a time, then we can make sure that we can secure the workforce to deliver those services. And the other thing as well is we talk a lot about dentists, and we talk clearly it's important that there's a dentist in the practice, but we've also got to think about dental hygienists and nurses, because without that complete team, the practice is unable to deliver a service to those patients. The second thing I would just say is just in terms of urgent care, and when we're talking about people in immediate pain, we do have a service through NHS 111 that will respond to that. And again, where we're aware that there are challenges with that, we pick it up, but that service is in place and patients can access care for urgent needs. Where we're trying to build up the capacity is for those patients to be seen for regular care. And clearly that's, as Ian says, there's a number of different ways that we can do to try and release that capacity to ensure that the right patients are going through the system and are being seen by those practices. Thank you.
Chair,
okay, what I'd like to say, sorry, Councillor Rhodes. What I'd like to say, Emma, in terms of what you've just responded to. So obviously the data and the statistics stack up and show up for themselves. Obviously, we were in this meeting last week. So it's either the information you're being given is very different from the reality on ground in terms of people just simply not having access. So people, I mean, we can give you the stats, which you did see last week, 111, how many have called and how many have been treated. Nothing compared to what we can even be proud of. So really, I mean, in terms of the challenges and the problems, we know you are aware of it. So the public are here, they want to hear answers. We cannot be telling our constituents that when you call 111, someone will come up to you and you will get attendance, because we know that is not happening. So for me, I'm actually not happy personally hearing that all they need to do is call 111, because that's not happening. And me and you know that. It's not happening.
Chair, do forgive me. I'm going to leave the meeting because I have another commitment. And thank you for giving me the time. And before I go today, I wanted recording that in the new year, we come back to this item and we show the public out there we're serious with their comments, because I'm afraid anybody listening today would think it's a very rosy world. And can I just say, it was not that the practice, as seemed to be suggested, they made the decision that they were only going to provide 2 days NHS. Now, what I get from my people, and I'm sure every councillor here, is that's public money that's going into the dentistry provision, and we want to see the public are getting value for their money. Thank you, Chair. I know my colleagues will pick up anything after today, and I look forward to that report and being with you again as soon as possible in the new year.
Thank you, Councillor Rhodes.
And happy Christmas to everybody.
And the same to you. Thank you. Okay, Councillor Smage.
Yes, thanks. I have a number of points. Children not being able to get a dentist, I think, is absolutely appalling, as is the case of people with dental pain not being able to see a dentist. My questions are about capacity and oral health, and you mentioned about the oral health needs assessment has been done. I would like to ask when that is going to be available, because when you look online, it's the 2015. And if you look at the actions online from the 2015, you will see that there are a lot of actions that actually are not happening. One in particular is about information as to who is providing NHS appointments, and I know that there are not a lot of dentists that are doing that locally. When I actually put in my postcode in the internet page that you're supposed to go to find out if NHS dentists are available, you either get not taking patients, only taking patients if referred, or we do not have the information. And one of the recommendations from the 2015 report was that there should be information up there for people to easily access, so that you don't have people having to ring round 30 or 40 practices to find out if they're taking NHS patients. You have somewhere to go. it was reported early in 2022 that 11% loss of dentists in Kirklees. But from your report, all I've really sort of got is there are a lot of problems that make it difficult to actually resolve issues. So what is it actually that you're doing or have been doing to actually increase capacity? Because it wasn't good before the 11% loss of dentists in Kirklees that was reported early in 2022. And what is the capacity going to be in the future? Ian, you mentioned about schools. Well, surely it should be preschools as well. It shouldn't just be schools. It should be preschool as well that the ICB is working with. And I had a look at your report from your meeting the other week. And I found very little actions. There's continue with the task and finish groups to define the operating models for decision making and transformation and service development. But at the minute, it seems to be all talk and no action, and people are needing action rather than talk. I think I'll leave it there for now, Chair, but I agree with Councillor Rhodes that we should have this in more detail, and we should have the oral health aspect as well, because I really want to know how the ICB are going to have the commissioning of the dental services and the oral health together to ensure that it is prevention as well as treatment. Thank you.
Thank you, Councillor Smith. Councillor Hutchinson.
Thank you. I fully support what Councillor Smage has been saying about site of the oral health needs assessment, which needs to be the basis for the commissioning of the service, and I hope it will do. But even before the pandemic, the government was only commissioning dental services for 56% of the population. So there was a large gap between what was commissioned through NHS England and the actual need. So I'm not sure how the transfer of commissioning to the Integrated Care Board will actually address that large gap. Another aspect I would be interested to know is that pre-pandemic, well, if you look at this period 2015 to 2017, if you remember those halcyon days when inflation was less than 2%, if that, dental charges increased during that period by 10%. So a greater proportion of increased funding for dental services was coming from patients' own pockets rather than through government funding. And I don't know, I know that there's exemptions for people who are on income-related benefits and pregnant women and young people under the age of 18. But I would be interested to know where dental charges fit into the assessments of how commissioning is going to take place when it moves to the integrated care boards. The other review I'd like to actually see is that's mentioned in the report is the review of the special needs service, special needs dentistry, which is, vital for so many people with special needs who often have terrible oral health. And the third question I have is that regular oral assessments are supposed to be an important aspect of detecting oral and tongue cancers at an early stage. And I would like to know what is happening with oral cancer detection and late presentations of oral cancer as the adequacy of dental services has deteriorated.
Okay, thank you very much. If you come back on these from Councillor Hutchinson and Councillor Smage, and then I'll take Councillor Swift and Councillor Ramsey after your comments.
Emma, do you want to come in first?
Yeah, I'm just really mindful that there's a meeting literally happening where we are talking about the needs assessment and releasing the needs assessment. So if I could just pick that up first, because then I can give some clarity. So the needs assessment that we've undertaken for West Yorkshire was completed in the spring, and we have done the place profiles as I've just described. The discussion that we're having at the moment is the best way of being able to communicate the outcome of that and being able to link that to our commissioning intentions. So that is literally happening as we speak, and I would expect that we'll be able to get some clarity over the next couple of weeks in terms of communication for that. And I'm just trying to work through the points that were made. We also talked about the release of the CDS, and I think a colleague there just talked as well about our commissioning of our dental services for the vulnerable and the special services. Again, that review is taking place, and we're going to be in a position to be able to discuss the outcome of that over the next couple of weeks. We have taken some actions again, which have been discussed as we speak, but we'll pick that up as well as a way of communicating so you can see the outcome, because that is clearly critical. Patient charges are something that are set nationally. Patient charges are not something that we can identify locally or review locally, but that doesn't mean to say that we don't petition with our central team to understand the challenges of the charging system. And then I think my colleague picked up about the lack or poor information in terms of practices that are accepting patients, new patients. Currently, there is no expectation or mandate for practices to keep information up to date in relation to whether or not they're accepting patients, whether or not they have a waiting list. That will change on the 1st of November. The regulations are just being changed to expect and allow us to mandate practices to ensure that their information is up to date. Now, the challenge with that is, unfortunately, if there isn't the capacity, then that doesn't improve that situation for patients. So clearly some of those initiatives that we talked about and articulated in the paper are to make sure that not only are we clear about whether or not practices are taking new patients, but also that they have the capacity to do so, because advising patients of a poor situation doesn't really take us into a better place for improving access. Thanks,
Okay. Thank you very much.
Could I come back in on
yes,
some of Councillor Hutchinson? So I think the point around oral cancer detection is a really great point. I don't have figures on that, but I will ask our cancer programme to get information on that, because I think it's a really important point. I think the things that you're describing, Councillor Hutchinson, around the commissioning budget versus need, around the policies around dental charges, I mean, I completely agree with you. That stuff is not within our gift in West Yorkshire. And I guess the conversation we need to get into is, what do we do collectively about things like that? What's our role in influencing upwards? I mean, on the one hand, we're absolutely aware of the challenges. You know, we hear the stories, completely, committed to trying to get this stuff right. On the other hand, there are things to do with the way that dental services are organised and commissioned that make it extremely hard, and both of those things can be true. So on the points that you're raising around the contract and around the national funding, we've got to work together, I think, with partners such as yourself, with MPs, with other ICBs, with organisations like the NHS Confed to try and change some of these things, because we're from West Yorkshire, and from NHS England's perspective, currently we're dealing with a set of really, really difficult circumstances, and that's what I was kind of alluding to, I think, when I was talking about this potentially a bit of a moment in April where this transfer to ICBs we could do something quite different in terms of those conversations upwards. But I completely agree. We're sort of slightly hamstrung by some of those arrangements, I think.
Okay. Thank you, Ian. Councillor Swift.
Yes. Well, in addition to the question I'm about to ask, can I just make a comment on the issue of oral cancer, and just the experience of a family member? It was her good luck that she actually did see her dentist about something quite different, and the dentist picked out a potential oral cancer issue. The system then worked extremely well, extremely fast. Once that had happened, negative, we hope, but she does feel very, very lucky that she had actually been seen by her dentist at about the right time, and the consequences, had she not fortuitously been seen at the right time, could have been quite serious. My question has been partially answered, I think, by comments about needs assessment and so forth, but it was really a plea for some numbers as to, probably aimed at Emma, what actually is the capacity that you are seeking to commission? What's the shortfall against what you try to commission? And is your current funding adequate to actually to commission that which you would like to commission? That's it, Chair.
Thank you. Councillor Ramsey first, and then you can come back. Yeah, thank you.
Yeah, sorry, I'm just really conscious of time. Yes, thank you.
Okay, I'll be quick, I promise. So first of all, I thought there was a really good point made about fluoridisation, and I don't know where that discussion is actually taking place, and I assume that's with you potentially, Ian. So I think that is something that we should be talking about. We're always in our strategies saying that we want to address the inequalities that we've got in healthcare. This is a real example of where we've completely failed to address inequalities. And I have been speaking to dentists recently to try and get an understanding myself, and I see that they are moving more to private practice because they actually lose money on delivering to NHS patients. And so a quick question is around the flexibilities that we will potentially have as we move into our newer commissioning arrangements, because some practices, I understand, get paid a different tariff, a higher tariff than other practices. The practices that get paid a higher tariff are likely to be in more affluent areas and are more likely to have patients like Ian, who are just there for a checkup and have a one UDA, and a profit might be made on that. Those practices in more deprived areas where they may need to take on new patients and actually be looking at band 3 kind of work, where they are likely to lose money, significant amounts of money for that course of treatment on that individual patient. Those are the ones that seem to have lower tariffs. So I'd be really interested to understand how we're actually going to start to address those issues.
Thank you, Councillor Ramsey. Emma, back to you.
There's an awful lot of information I could give in answer to both of those really significant points. I think it's hard to break it down to make it. So we at the moment have a committed contract. So we have providers that have a contract in place. We have funding to ensure that that is delivered. Where practices struggle to deliver that contract is where we're then able to be flexible with the money around the system. So as I think Ian mentioned earlier, we're building capacity in where we've got practices that are struggling to deliver against their core contract. The unit of dental activity was agreed in 2006, and unless the practice wishes to rethink that, we can do nothing about it, unfortunately. So that variance of tariff is in place. We can do very, very little about it. However, across Yorkshire and the Humber, we have worked out what our average is, and we will commission from this, or have done for the last year, on that revised tariff. So the tariff for Yorkshire and the Humber starts at 23 and goes up to around about 46. Our average is £30.40. So where we have the opportunity to offer additional activity or to recommission, we will do so at that revised tariff to reflect the challenges of that local area. So I just want to just give some confidence that whilst we've got some inherent problems from a legacy arrangement, we are doing our best to try and address that for the longer term. I think the needs assessment that we talked about and the inequalities, etc., I'm wondering whether or not our colleague who has developed that would be welcome to come and talk to you at the session that you have at the beginning of 2023. Martin Ramsdale has actually developed this, and I'm sure would be delighted to work through some of the more detailed questions that colleagues have asked that I'm not necessarily in a position to do so. But if that would be helpful, then I'd be very happy to ask him to join that conversation. I think Ian can probably pick up the question around fluoridation, if that's okay.
Yeah, I mean, I guess there's a point around transparency here, isn't there? I think, and I think, you know, we try to be quite transparent in the ICB, but I think all of this information around the oral needs assessment and what's really going on, I think we should aspire to be as transparent as we can with that information. We're picking it up anyway, anecdotally through Health Watch and other partners, but I think we've got a duty around that. On fluoridation, I think that So as part of the Act, the responsibilities around fluoridation passed from local authorities to the Secretary of State. As you'll all know, it's complicated. Firstly, I think from what people tell me, and I'm not a public health expert, I think the evidence around fluoridation is really, really clear in terms of the benefit it offers, you know, from a really young age right through life. I think that there are areas like Hartlepool that are naturally fluoridated, and there's other areas where fluoride's been added, and you know, so you've got a really nice ability to contrast those different areas, and the evidence base be really, really clear. There's the complexity is that it's, you know, water runs in you know, from places to places, and you need an agreement, I think, across Yorkshire and Humber to be able to get something right for our areas. There's feasibility studies required, there's consultation required. Fluoride is one of those issues that is, you know, probably as politically charged as any, really. You know, if you imagine sort of some of the conversations happen around the vaccine, this is something that people won't have a choice over. It'll go in the water, and if you drink the water, you're getting the fluoride. So I think we shouldn't underestimate the strength of opinion on both sides. But you know, to the point, if we're serious about tackling these issues and we're serious about inequalities and children's oral health, then it's absolutely something that we should be looking at. And I think across the ICBs in Yorkshire and Humber, that's a conversation that we can have. And I think what we need to do is we need to then, you know, express a kind of a almost an intent to look at this with Secretary of State, and then there'd be a process around feasibility studies, consultation, those sort of things. But that's a conversation that we'll pick up with the other ICBs. And Councillor Swift's gone, but I hope his family member. I hope it is positive news. I'm glad that got picked up.
Thank you very much, Ian. Yeah, in terms of fluoridation, which was one of the things we picked up our scrutiny board, which is we were looking at preventative measures, not just, you know, where we are now as well. And of course, fluoridation is huge. And coming from West Yorkshire, so there's many of us now, it's not just one authority, you know, looking into that is huge for us. And you can see the need on us pressing. If we have to press the Secretary of State, whoever we need to press, we need to do that. I remember at our scrutiny last year, the first thing one of our board members said, if there was anybody he wanted around the table, was the government, that they needed to answer some questions. But unfortunately, we can't bring the government into our scrutiny board, but through yourselves and through, you know, the ICBs at the Dental Institute, we can. Now, because of how important this item is to us, as the chair, we are willing, and I know I speak for the rest of the board members here in wanting to progress with this item and not just leaving it here, because there are still unanswered questions that we have. We still have our constituencies wanting answers. And what we did differently from what we're doing today in Leeds, and I'm glad I've seen Angela Brogden, who's our scrutiny advisor here. We were able to get clinicians in, so the dentists themselves. So we had first-hand knowledge about what they were going through, the challenges in their dentist surgeries. We also had patient voices. We had health watch. So we had practical knowledge, example, experience from people going through this. And I think that will be beneficial to this board as well in our next meeting. Mike, if we have to make it a one-item agenda so that we can have enough time, because I do know we're out of time now. People have got other things to do and we need to end this meeting. Could we look into that for our next meeting? I mean, myself and yourself can have a meeting outside of this today to discuss that forward and how we can bring other partners around the table. The good thing is, Ian and Emma, you know enough about the issues and what we would like to see doing. So when we're coming back, we are talking about the now. I really like what Councillor Smith said. Yes, the future is great. The future we don't know yet because we're not there yet. What we have is our now. So that is what we really, people are using pliers to take their tooth out and things like that. You know, we need to know what can be done straight away. So I'm sorry, I'm not going to have to take any. Councillor Swift, I can see your hands up. I don't know if that's a legacy hand, but I will not be taking any other questions again because we actually need to wrap up now. So I'll now bring in Mike.
Just to say, Chair, I mean, I agree with exactly what you said about a one item agenda. and maybe we look at doing something. We talk about scrutiny in a day in Colesdale, so as you know, perhaps a slightly longer session with one of those items. I could just say something about resources. Now, in the conversation earlier on, I think three of the 5 councils talked about having their own item on dentistry. I guess if we want to focus our efforts across West Yorkshire on this session in the new year, then perhaps we don't put too many demands on Emma and Ian to go to all the places to talk about dentistry, but we publicise this item as well. And the point about clinicians and public health, you know, is well made. And so perhaps if we put a bit of focus on this and make it a bigger item. The other issue about resources is I'm looking at, I'm really pleased all the other scrutiny officers are here today. I'll be looking at for support from 1 or 2 of them in this, because it's going to be quite a big bit of work. Thank you, Chair.
I'm very certain they'll be happy to help. I can speak for Leeds. I'm not sure about the other authorities, but I definitely know they will be happy to help. Yep. Councillor Soloway is giving me a thumbs up. Is that a thumbs up from the rest of the councillors and your authorities? Is that a yes? Fabulous. Thank you, Councillor Hutchinson. Okay. Right, this is our last meeting for the year. I don't even want to believe it, but yes, it is. And so I don't think we are meeting until February. So it's a very Merry Christmas from all of us. And thank you to Ian, thank you to Emma and the team for coming. Members, as always, can we show them some gratitude like we normally do to all our speakers?
Yeah, thank you.
And can you see? So thank you all very much for coming, and please do not hesitate to contact myself or Mike if you've got anything that you need to share, you know, just before February, where I'm more than happy to take it on. So thank you all so much for being a great team, and see you all in the new year. Blackout from here.